So week 7. Now, this is the exam. It's done now. It is a great time. Start that project. If I don't have one of your diagnoses, let me know. Now, don't be a fool that you have to have a diagnosis from the modules where it gives you a list of like 30 or 40 names. You do not have to choose one of those. What I'm put those down there is just in case you couldn't think of something. But something that children have that you had, your child had, your sister's kid, your aunt, your uncle, something you want to know more about. And it actually makes this project less of work. And actually, it gives you that information, something that you've been meaning to look up, and now you sort of have to for school. Okay. I've had parents, mothers tell me about their daughter and things like ADHD or things with immunocompromised disease, all things. I've learned about many things. It's a great time to do that. Again, make sure you get that diagnosis to me. You have a discussion question this week, and you do have a CJ Sims. Next week, you've got a lot of things. You not only have a project due, you also have a longer case study. So it's a lot of work. I highly suggest start getting your project in, and you can let me know, hey, I've turned in the first part of it. Can you correct it? I will correct it. If it needs changing, I will tell you, and you can change it and get a better grade. Okay. So, but don't ask me on the last weekend to do it because I have 75 almost different projects that are coming in. So you get it done earlier. I'm going to score it earlier and I will get it back to you. So you could see how the changes would be. Any questions? All right, let's go ahead. Let's do the Cahoots. This week, week 7, it is child with cerebral dysfunction and endocrine dysfunction. So let's get it to where I need it to be. And here we go. Did some of you have your school children home today because of President's Day? Yeah, my grandson was with me all day today. So I've actually enjoyed him. And yesterday was my daughter's big 4-0 birthday. And she's in her 3rd trimester pregnant with another little boy. So we are very excited. She worked hard for that, very hard. All right, let's get going. Cerebral or endocrine dysfunction. Growth hormones is administered by what route? Now, this is important because growth hormone is for that child who is short. Growth is shorter than what the whole family would be. I mean, if a whole family's short, you can't make a child grow more than what their hormones will let them grow. But it's just like giving diabetes. It is a subcutaneous injection, usually given daily. So it takes a lot of compliance and commitment by the family in order to go through this therapy. What they do is they continue growth hormone subcutaneous until they stop growing less than 1 inch a year, which is usually that pre-adolescent sort of area where after that growth spurt, that's usually when they stop because they won't grow anymore. Highest priority of a patient diagnosed with syndrome of inappropriate antidiuretic hormone. Well, let's look at the name. Inappropriate antidiuretic. Too much of against urinating hormone. That's what that just told me. So if you have too much of against urinating hormone, what are you going to see? Well, you're going to see a child that's not urinating, right? So intake, output, daily weights, anything with fluid balance, always think of adult children, doesn't matter. Fluid problems, intake, output, daily weights. It'll really tell you a whole collective story about that patient. Which of the following are signs of syndrome of an inappropriate antidiuretic hormone? Syndrome of inappropriate, too much against anti-diuretic urinating, too much against urinating hormone. I'm not urinating, right? It's going to be a decrease in urine output. Now, the other side is diabetes insipidus. These are the pituitary glands, okay? We have an anterior and posterior pituitary. When we talk about fluid balance, it's the posterior pituitary gland. When we talk about growth, it's the anterior pituitary gland. So each side does either growth or it does fluid balance. What is important to cover when teaching the family about propionathiazole? Now, this is a drug that's given for hyperthyroidism. So if you have a drug that you're taking that's for hyperthyroidism, it's to block the amount of thyroid hormones released. So it slows it down to where it needs to be. One of the side effects with this one, which is different, is that it causes leukopenia or a decreased white blood cell count, which can cause a child to become sick, risk for fever, and sore throat. So these patients are taught when they go home, if your child is complaining sore throat, fever, let the doctor know. They'll probably put them on prophylactic, and maybe they'll come in if they can do a lab drug level to see, is it the medication causing this or is it really a viral or bacterial infection? So it's, what is it? A multi. An initial sign of diabetes insipidus. So this is opposite of anti-diuretic hormone. So it's hyperdiureticing. So too much urinating. This is a child, posterior pituitary, that's drinking, and is never satisfied, and urinating. And even if you stop the drink, they still will urinate. So, diabetes, there's two types, and it's not uncommon. Many students will pick polyphagia for diabetes insipidus. Let me get you so that you understand why it's not. Diabetes insipidus has only everything to do with fluid balance. So polyuria, I urinate a lot. Polydipsia, I'm thirsty. Now, has nothing to do with blood sugars, has nothing to do with carbohydrates and, the absorption of that. All it has to do is with fluids. Diabetes mellitus, you cannot digest sugar and your body's hungry because you're not getting sugar. So that's why diabetes mellitus, you're not only thirsty and urinate a lot, but you're hungry because the carbohydrates can't be used by the body. Okay? There's no insulin. That's the difference. And you will see this on exams, whether it says the NCLEX, diabetes insipidus, mellitus, the signs and symptoms, and the differences of multi. What are the clinical manifestations of juvenile hypothyroidism? Well, hypothyroidism, whether it is adult or juvenile, are all the same except hypothyroidism. You need a thyroid hormone in children for their growth and their cognition. At birth, a child who has not stooled, this is one of the things they'll look for. So we've already talked about cystic fibrosis. They cannot stool at birth, and that would be something we do the sweat test and look. Also, it could be hypothyroidism, no stool in the first day or two of birth. They're going to check the thyroid gland because if they don't get enough thyroid hormone, they're not going to grow. And also, the cognitive level, they're not going to doing those fine grasping or lifting their head on time. They're just not going to be doing it. Now, whether you're an adult or child, the dry skin, sparse hair, constipation, cold intolerance, weight gain more than a weight loss, okay? And we know in children, yes, it is decreased growth. A child's had a simple febrile seizure. What education would you provide the parents? Febrile seizure. My first grandson had febrile seizures. He started them about 18 months. So I watched a parent go through all of that emotional turmoil. The one thing and the biggest thing, seizures, febrile seizures or epilepsy type seizures, it doesn't matter. We need to have them protected with the seizure. Many times they like to vomit. Many times arms and legs are flailing. And if there's stuff around that they could hurt themselves, cut themselves on, making sure toys and things are out of the area as they're moving and jerking. Okay. Having the suction at bedside, not to put in their mouth, no, but if they vomit, to clear the area around where they're breathing. Okay. So protect the area, side rails up, bedside down, and then turn them on their side in case they vomit. What type of seizure is when the body's jerking, foaming at the mouth, and the child is rendered unconscious? And it's used to be grand mal, right? Today we call them tonic clonic. What notable sign may indicate increased intracranial pressure in an infant? One of the things about infants, if there's something neurological that's going on with an infant, you can literally hear it when they cry. Their voice is an octave higher. It's almost like nails on a chalkboard. You can like, oh, it's not a normal cry. So that high pitched cry, sometimes you'll see the scalp veins bulging. You also will see fontanelle bulging, not just crying, but at all times. Okay. So again, that bulging, that cry, that distended neck veins, scalp veins that we might see, that's telling you something's going on. All of the following increase intracranial pressure, except what? I mean, these are things we need to know if we have a child who, let's say, had a fall and it has increased intracranial pressure. We don't want to do anything to make that worse, to cause more damage to the brain, right? So we're going to be careful with intake and output. We're going to be careful with if they have intubated and they have an airway, that suctioning, that coughing. We need to do it once a shift to keep an airway open, but it shouldn't be done more than that unless it's absolutely necessary. Now, bradycardia, tachycardia, Elevated blood pressure might increase cranial pressure, but tachycardia does not increase that pressure. What findings can alert you to a head injury that's getting worse? So you have a child that came in, let's say to the ER. They had a sports injury where they hit the knee of a defender and they were knocked out. And rescue brought this child into the ER for evaluation. You're the nurse. When we start seeing them slowly change in orientation, they might understand when they came in, they're in an ER. They might ask you things like, so was I safe? Or did I win the game? Or when's daddy coming? When's mommy coming? And it's like you're getting that over and over again. And then it's becoming more and more drowsy. That is the problem. It is increasing the problems in the brain. Multi. What does it mean when you see a fixed and dilated pupil after a head injury? If you've ever worked, in a emergency room, when we have falls off of balconies or trees or whatever, one of the first things we look at is their pupils. Are they big? Are they dilated? Are they reactive? It's telling us probable outcomes. Okay. Now, if they're fixed and dilated, and they were okay earlier, we've got a very short window to decrease the pressure in that brain so we can decrease the amount of neurological damage. Now, what happens if there's all of this pressure there? It's in the back of the head where all of the brain center is. It's, all the heart rate and the blood pressure, the brain stem, the major brains of your brain. It controls it and it's swelling. Once it's there, 5 minutes, hypoxic, there's going to be permanent neurological damage. What medication can be used for a child with cerebral edema due to a fall? Well, we have swelling in the brain. What medication decreases swelling, specifically the brain? And it's called mannitol, isotol, mannitol. It is specific for the brain. Remember, this is a drug that goes through a filter, so you don't want that crystallides in it, and it works very quickly. Now, I always say it's just for the brain. It can also be used in toxic ingestions, drug overdose type things, or it also can be used in renal failure. But mostly, we will see this in when you have all of the increased intracranial pressure. Ray syndrome. Ray syndrome's because of aspirin, and there's a metabolic disorder with it. Happens in children when we just give aspirin instead of giving acetaminophen or ibuprofen. Now, we have learned Kawasaki gets aspirin, right? It's part of, the way that we treat it. But just generally, no parent, if they ever mention, well, I'll give aspirin if they have a fever, no, they should only give acetaminophen or ibuprofen after 6 months old. Febrile seizures usually occur in what? The one thing about febrile seizures is luckily children do outgrow them. My little grandson, as I said, he was about 18 months when it started. He actually only had one febrile seizure, but the mother carried thermometers, at least two, in her purse, always had ibuprofen, acetaminophen. and always acted with medications before, she would even think. So she actually did prevent many seizures, but usually by about 6, they grow out of them. And again, how do you treat a febrile seizure? It's due to a virus. You're going to treat the fever, acetaminophen, ibuprofen, liquids, and rest. Just what we would do. Childhood hypopituitarism results in which condition? So this is the anterior pituitary gland. Remember, posterior is all about fluids. The anterior side, which is all about growth. So we can grow too much or we cannot grow enough. And we do have conditions. One of them is called dwarfism, due to not enough growth hormone being delivered. How would you describe precocious puberty? We've been giving the standard stages, right, of development and menarche and puberty and trying to guess. Well, precocious puberty is different. This is something that you have girls that are extremely young that are now getting breast buds and almost go into their period. And because they're getting these sort of physical changes, many other children, they're not nice and tease them. So parents and children decide to stop them from having puberty early. There's something called Lupron that stops the puberty until when we want it to start normally. And that's usually about 12 years old. Almost dying. What lab values are important to monitor with a child with congenital hypothyroidism? Child, adult, doesn't matter. What are the hormones? Thyroids. So T3, T4, TSH, those are all your thyroid. Growth hormones is not the thyroid, that's the anterior pituitary gland. And cortisol is the steroid, it's your adrenal gland. How can you monitor a child with hypo or hyperthyroidism? So, what does the thyroid do? What did I tell you specifically in children that we need it for, which is different than adults? And that's looking at growth, right? How do you measure and what do we do every visit on every pediatric patient? From baby up till whatever, pediatrician's office, you're going to be weighed and height. And that's height and weight. And that does measure growth. It measures if they're getting enough nutrition when they're younger, right? Besides all those developmental things, but it's telling you you're getting nutrition, gaining weight properly. What acid-base alteration would you see in a diabetic child with Kussmaul's respiration? Kussmaul respiration is the slow blowing off respirations. We see it specifically in diabetes, right? DKA. What Kussmaul respiration is doing is the body is trying to compensate for the metabolic acidosis that's occurring because of what's happening with the sugar and with ketones. So in the respirations, it slows down and starts to blow off the acid, trying to correct that ABG out. And that's what happens with that. A multi. What would a child with Cushing syndrome look like? Well, what does Cushing syndrome do to? I can tell you when I first started my thing with rheumatoid arthritis and the treatment, they didn't know what's going on. They put me on high dose steroids, and I ended up with Cushing's syndrome. I gained, about 60 pounds. My face was this big. I have hair on my chin that I never had before. And the only thing I didn't get was those red, ruddy cheeks. And I didn't really get, the striae is part of it. But you do. Cushing syndrome is an adrenal problem, too much steroids, whether it comes from, exogenous in the body, or is it you were given a prescription for steroids and it was too much or for too long of a time? These are what you see with it. Now, there's a lot of muscle wasting because of the steroids, okay? Now, arms are skinny, legs are skinny, but you get these big fat cheeks and this big fat chunk and your abdomen. Also, you're going to see hair, whether it's on the chinny chins or different places, more of it. These are things that you see with Cushing syndrome. Now, how do you treat it? Well, if it's due to you're taking steroids, you have to slowly taper it off. A multi. You walk into a child's room with a fever of 104.6 and they're having a seizure. What are you going to do? So you're having a seizure. What is your responsibility? Run out of the room and scream, help! So you see a child and you see a seizure going on, and you still don't even know they have a fever yet. So when you go over and make sure the side rail's up and you're turning them over to the side, you feel them and you know that they have a temperature. Probably see some big red cheeks too, right? Also, as you're protecting them with side rails up, patting them with blankets or pillows or whatever you possibly can. Also, children, they put everything in bed with them. Their crayons, their pencils, their toys, their cars, making sure all of that's out of the area because they can scratch on that and they can injure themselves, okay? And again, there is suction at the bedside in case we need it. Autoimmune disease of the thyroid gland. No, we have hypothyroidism and hyperthyroidism. Autoimmune thyroid is one of those conditions where removal is not an option. Surgery you cannot do. You must treat the dysfunction of those thyroid hormones. Usually it requires a combination of thyroid hormones. Usually we see this in young girls, young, older school age, young adolescents when we first see it. And it is an autoimmune disease, requires medications. Remember, thyroid medicines are given in the morning because it gives them a boost, wakes them up. Okay. Addison's disease. The adrenal gland. Do you remember what that does? It's not enough. A lot of times, Addison disease has a thing with a newborn baby that there's no sex. We don't know if they're a boy or girl. They're born with different sex characteristics, could have a penis and a vagina, different of both of them. And it's in combination with Addison disease. Those children are going to require cortisol and aldosterone injections for life. And of course, increasing with stress and as they grow, etc. Multi. A ventricular peritoneal shunt. This is a catheter that goes from your fourth ventricle behind the ear in front of your chest down into your peritoneum. So we have a tube, it's draining fluid. So what is it used for? This is used for that child Who can't drain cerebral spinal fluid adequately? And without a shunt, the head would be big with hydrocephalus. So this decreases the fluid, the water on the brain, the hydrocephalus. What is your responsibility as a nurse? Well, behind the ear, you're going to see like a lump, and it literally is a pump, but it's only for the neurosurgeon. Okay. We don't touch it. The only thing we do is do a measure circumference the head. And we do that at the beginning of every shift that you work. If it's getting bigger, shunt's not working. And again, if we see the fontanelle getting too, caved in, well, then we're too much. So again, fontanelle, head circumference, all those things telling us about a fluid. So, a common sign of Graves' disease, which is hyperthyroidism, includes blank or protrusion of the eyes. I had a girlfriend whose eyes were big like that. And everybody always asked her, "Do you have high thyroid?" She goes, "No, I don't." That was just her, it was her family. It's called exophthalmos, and it's part of hyperthyroidism. There are eye drops that they can take, and it can decrease them a little bit, so they're not sticking out as much. A multi hypoparathyroidism as the symptoms of tetanic muscle contraction and blank. Now, there's a thyroid and there's a parathyroid gland. Thyroid gland has thyroid hormones. The parathyroid, all it does, it regulates calcium. Now, what is calcium good for? What do you do with calcium in your body? Well, calcium, magnesium are all about muscle strength contractions. So, not enough calcium, you're going to be weak and floppy, and you're going to have low calcium levels. On the other hand, too much hyper would be tetany. You're in spasms because it's too much muscle contractions going on. Parathyroidism, it was on the HESI about what it was. So I'm all dying. What are signs of hyperparathyroidism? I just told you. What is it? Too much calcium. You're in spasm. It's so much. Your muscles are contracting on overdrive. So with that, there's nausea, vomiting, and then confusion with it because of the contractions and allowing doesn't allow blood going into the brain, and then the numbness in the extremities because you're in such spasm. Again, is that muscles allowing blood to flow? What does the parathyroid hormone do? What did I just tell you? So parathyroid gland, it regulates calcium, gives it enough or decreases it. Again, what's calcium good for? Calcium, magnesium, it's all about muscle and contractions, whether it's voluntary or involuntary muscle contractions. You need calcium, magnesium at proper levels. Which of the following might be a cause of an adrenal crisis? Adrenal crisis, Addisonian crisis. Remember the adrenal gland, cortisol, aldosterone. It's all about steroid stuff going on, right? So, an adrenal crisis is when you're on all these steroids and all of a sudden you stop, and the body does not like it, and you feel extremely horrible. And you go to the ER, and all they do is they give you a dose of steroids. It corrects of what's going on. you withdrew too quickly, and then put you on that, tapering down dosaging. A multi. Cardinal sign of diabetes insipidus. So let's see if you remember here. Which ones are they? Diabetes mellitus, diabetes insipidus. What's the difference? So diabetes insipidus is only fluid, thirsty, and pee a lot. Polyphagia is diabetes mellitus, and they're hungry, polyphagia, because the body cannot absorb and use the carbohydrates, the sugar, because there's no insulin. So the body's hungry. So it says, get something to eat. You're hungry. So diabetes mellitus is hungry. Diabetes insipidus, they are not hungry. They're thirsty, thirsty, urinate, urinate. One of the things about infants, and the one way that we can diagnose them as we are trying to do it, is if all of a sudden we give a baby that we're suspecting diabetes insipidus a bottle of water, all of a sudden they stop urinating. So it's like, wait, they've been urinating, and all of a sudden we give water and they're not thirsty and they stop urinating. You're like, okay, there we go. Multi. A congenital hypoplasia parent teaching should include. This is hypoplasia of the adrenal gland. I told you it's like an Addison's where you're not getting all the proper hormones and the baby doesn't know what to do. So during its growth, we don't know, are you a boy or are you a girl? So one of the things we do know, no matter what we assign, what gender, it's not going to be able to have children itself. So looking at what they have, ultrasound, sometimes, they do blood testings and hormones and make the best choice. Then they assign, is it a boy or is it a girl? These children will be on cortisol and aldosterone replacements for life. Their body's not getting it, and it's something that they will be for life. What causes type 1 diabetes? I like the math test. Bob has 36 candies. He eats 29. What does he have now? And the one word is diabetes. Does eating too much sugar cause diabetes? No. It's the body just does not have the beta cells in the pancreas, and insulin is not made and can't digest blood sugar, and the body says, I'm hungry. What am I going to do? So all that blood sugar is in there, all the carbohydrates are there, but the body's hungry and it says, okay, let me eat the proteins and the fats. It's another way to get food. Byproduct is ketones. So you have elevated blood sugar and you have 4 plus ketones. You have 4 plus ketones, 4 plus sugar in the urine. And this is a child who needs to be given regular insulin, slow IV continuous to break that sugar up, to give the body the nourishments it needs, and to do it slowly. Monitoring, of course, potassium, monitoring the ABG, the blood gas. I saw one child, type 1 diabetes, come in DKA. Blood sugar was over 1,000. His ABG was 6.89, which is literally it doesn't exist in life. But this child made it. We gave him fluid bolus. We gave him the insulin, a slow continuous, and we brought him back and we did get that child home. But that's probably one of the scariest highest levels of stuff that we see. Statement about a pheochromocytoma. This is an adrenal tumor. Extremely hard to diagnose. We call it a simple methodic tumor. It's one of those similarities to your Wilms tumor. If we over manipulate it, it can cause these little histamines to go out, catecholamines, and cause elevated blood pressure, elevated heart rate. And these children come in, right, all of a sudden their chest feels tight, they got flutter in their neck, and it happens periodically. So it's hard to figure out. They usually go through cardiac workup first because it's the heart rate up and down. They figure it has to be the heart, right? And then they go ahead and they do a CAT scan of abdomen and they find this. Nursing care. What are we concerned about? Well, let's see. This heart rate can go up, blood pressure can go up. We'll be monitoring it close to see if this child complains of those type of things. Take the vital signs, see what the heart rate gets up to, blood pressure gets up to, and know that this is a possibility. Multi. What action should a nurse implement in the care of a patient with a pheochromocytoma? Again, that's your adrenal tumor. So we're looking for the sympathetic, that epi type, epinephrine type response, blood pressure up, heart rate up. Those are things we're looking for. Pheochromocytoma has nothing to do with the weight gain. It's nothing to do with blood sugars. It's the adrenal gland, and it just is that adrenal epinephrine type of rush that comes out. So those are the things that we monitor the child for. Multi. Nursing care of the unconscious child include you have a child who's maybe has a concussion. What do we need to do? Well, yeah, concussion, head injury. We are going to be doing neuro checks at least every 2 hours and more frequently, in the very beginning, but usually it ends up every 2 hours. Always checking vital signs and temperatures important in there. Because if it's an elevated heart rate, was it due to pain? Is it due to volume? Or is it due to a temperature? So to look for those things. And of course, unconscious head injury, we don't want over bolusing of any sort of fluid. So intake, output, fluid balance, very important. Head injury, unconscious. What might you suspect if a child feels jittery, sweaty, and is dizzy? What do you think that could be? So this is typical classic hypoglycemia. Now, a child feels, they're telling you, I feel jittery, I feel dizzy. What would you give them for hypoglycemia? Well, in this case, they're talking. They can have orange juice, they can have milk, they can have, a little sugar candy, something. Give them something with sugar, right? Now, if they become unconscious, that would be the glucagon. Again, questions regarding what would you give a child with hypoglycemia depends on patient condition, awake or not. Symptoms of DKA are can't get my sugar, don't have any insulin, so I'm gonna go after proteins and fats. My byproduct is going to be ketones. Still can't use that sugar, so excessive hypoglycemia. And one of the things you'll never forget once you smell it, children with DKA have this fruity breath. Now, let me explain to you what it smells like. Take a ripe, good, juicy peach, put it in a Tupperware container, tightly lid shut, put it in the refrigerator for a month. Forget about it. Take it out, and now it's almost rotten, right? Take off the top, and that rotten, sweet smell smells like the breath coming from these children. It is the sugar, it just oozes out of them. In fact, sometimes these children are DKA before they even tell you. They're pale, they can't hold their heads up, and you can say, oh yes, that is a DKA. You can smell it. Multi. An adolescent with a BMI above 95% has been urinating a lot. What tests can you anticipate doing? Now, that could be a lot of different things. So, urinating a lot could be a UTI. Rule out the simple. Urinating a lot? Well, could be, diabetes, hemoglobin A1C. And urinating a lot, are you getting rid of too much potassium? Always look at electrolytes. Did you see three different things, one concept? You got to think of what all it might be. Diabetic ketoacidosis is caused by. No, I can't eat sugar, so I want to eat proteins and fats. My byproduct is going to be ketones. So, don't have insulin, I'm going to find somewhere else to eat. And the only other types of food products, can't do carbohydrates, it's fats and proteins. A multi. A child's admitted with blood sugar greater than 600 and large ketones in the urine. Priority intervention. What do you do first? I mean, we can tell blood sugar greater than 600, large ketones, definitely DKA. How do you treat it? What's the number one? And the number one is get that IV bolus in. Let's dilute that blood sugar and ketones now. Also, a slow, continuous, regular insulin drip. And there's protocols about how often you do blood sugars and decreasing that insulin drip so that we don't end up going in the opposite direction and not enough type of blood sugar there. Okay. A diabetic child complains of feeling jittery and the blood sugar is 45. What's the best treatment for this child? So is complaining. That was the key word. We're going to give some orange juice. Yes, we are. Your patient's experienced a head injury. What would most concern you? Think about head injury, swelling inside the brain. What all is possible that could happen? And it is that decreasing urinary output because of the extra pressure on the posterior pituitary gland, which is in the middle of the brain. Yes, excellent. Very, very good. A multi. How do you detect diabetic ketoacidosis? As in, what is it? What's that classic thing? So if you had to think, it's high blood sugars in the presence of large ketones, right? Absolutely. So blood sugars in the urine, ketones, and blood sugars are elevated. Dehydration, we don't really say that. But yes, we give the boluses to dilute everything, but we don't say dehydration. So multi. What would alert you that a child's head injury is deteriorating? So all of a sudden, you're going to see things. Ache is getting worse. They're getting more and more difficult to arouse, restless, hypoxic going on, swelling going on, confused. Those things we're starting to see. They're starting to vomit. In children, head injuries, you see vomiting, not necessarily with adults. And that vomiting is not going to be related to eating at all. So, when you see this, almost like a brain tumor, if you think of it, headaches getting worse, vomiting not related, those things, but it's also that mentation becoming more and more confused and not as alert. Your child's been diagnosed with bacterial meningitis. What's the nursing priority of care? Now, child comes in complaining of nuchal rigidity, fever, rash. We do a spinal tap. Now, we all think that meningitis is all bacterial, that meningitis all gets antibiotic. And no, there's viral and there's bacterial. So, how do we treat? Oh my goodness, viral meningitis. It's just treating it symptomatically. It is fluids, it's rest, it's acetaminophen, ibuprofen, and that's it. Now, bacterial meningitis, your priority is that infection. Start the antibiotics. Furthermore, if this child is being admitted to the hospital, they have to be in a reverse flow room and they need that for 24 hours. So 24 hours after the antibiotic is started, then they don't need to be on all of that extra isolation and airflow and masks, et cetera, et cetera. What is the primary cause of injury associated with submersion? As in, you're drowned, you go under, they find you at the bottom of the pool, and we see you go in, pull you up, get you on the side, and before rescue comes, you're already awake and alert and you're running around, and everybody says, I'm fine. Well, the problem is the cause of injury is due to hypoxemia because the lungs are filled with fluid. Now, the damage to the lungs can take up to 72 hours later to exhibit. This child running around looking like he's fine, we saved him from being drowned, could go into acute respiratory distress syndrome, a day, 2.5 days later. So these children are all admitted into a step down ICU with an O2 sat monitored, closely monitored, to see if they're going to go into this respiratory distress. And last question, multi, which CSF lab results correlates with bacterial meningitis? So I always, looking at these, I want to know viral or bacterial. First of all, cloudy means bacterial. There's white blood cells in there. Second of all, bacteria loves sugar and it eats it. Yum, 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 but does not like protein and it leaves it there. So elevated white count, bacteria, elevated white count, right? Just like you would see in a CBC, infection, bacterial, elevated white count. Also, no blood sugar. Glucose will be low in it because it loves sugar, bacteria does, and protein is there. And then how would we treat it? Priority, antibiotic. Amy, good job, Amy. Number 3, good job. Number 2, Emily, good. Number 1, Dejanaria. Number 4, a DA and a Shannon. Well, good job. Good job, guys. All right, so week 7 is done. Again, as I said, please get your and try to start doing those and give me the names of your projects that you want to do, okay? So again, the exam. I know that's your big thing and you want the grades. You're not going to know until Saturday, okay? Um if you're having a moment, you can make an appointment, see with me. But most of you did amazing. There, I believe, 2 grades just below. So not bad at all overall. Any questions? That's all I have for you all, guys. Have a good day. Thank you so much.